Okay, so this is going to be the meeting here is the agenda, if you want to call it. So I did a practice run through, and it really was right about 45 minutes. I'm going to try to shave off even more time. I'm hoping with more and more practices, I'll shave off even more and more time. And the CNAs in here, they're the first part of this meeting is information for you as well. And then we'll get to a slide where it says, okay, CNA part is over. You're free to leave the meeting, and the rest is nurses specific. You're more than welcome to stay. I'm not kicking you out completely, but just letting you know that you're free to leave at that time. Okay. Okay. So the CNA bathing pathway, how to chart baths correctly. I was asked to briefly review this, and I did include this. So I've got a PDF of this, including all the documents that we're going to look at if you guys want it for review. So I included snapshots here, but let's see. So, oh, I need to share that. We're going to go through the ProTouch pathway really quick and view that. So the biggest thing that I'm hearing is a couple of the CNAs have come up to me asking, what about this order that we're documenting against? And on the work list, you'll see this bath shampoo order. That is just a reminder on the work list. Yes, you still have to document against it that was completed, but it even says for it to be legal, for it to be, you have to document the hygiene. So go to data collection, enter the time that the hygiene was completed. You'll see hygiene. These are the actions that you perform for the patient, actions that you, so you'll click actions performed. And then this is where you'll pick exactly what specifically you completed. Hey, Talia, I'm going to put your name down on the roster. And if I miss anyone as I'm saying, ah! Oh my God. There's a spider that just jumped out from under the page that I am just writing on. Normally I do not sound like a girl, but that qualifies. Okay. No more spider. Okay. Partial bath or full bed bath. And then you'll go to proceed, hit process 3 times. This is what it will look like, and flowing over to the hygiene flow sheet. And that completes the documentation. Literally, it's 3 clicks, but it is 3 extra clicks. But I really wanted to show you guys in person what it looks like on ProTouch. Screenshots only. They're nice for what they are. Maintaining a patent G-tube access. So another thing that I'm hearing about on the floor, the G-tubes are getting blocked up with boluses, or a hard bolus of tube feed. Anytime that anyone sees a tube feed on hold, or has been on hold, or will be on hold for a while, CNA specifically, I'm speaking to you also. You are our eyes on the floor. You're going to see these patients a lot more frequently than we'll be in that room. If you see that this tube feed has been on hold for a while, let us know. We'll go in and we'll flush it. Nursing and nurses, if you are giving medication or any time for any reason that you disconnect that line, that tube access, you're going to flush before and you're going to flush after. I have actually had this where it let me know that something happened to that placement where it was when I was flushing it after accessing it. Outside of that, it also clears any sticky, gunky, anything, maybe medication sticking together. And you're going to flush after every single time that you access it, disconnect it, or place it on an extended hold. And by extended hold, I mean more about 30 minutes or longer. All right. Yeah, so we'll flush it with about 20 mils of water and then restart the pump. There's a really awesome action on the kangaroos, and when you push hold, there is this flush now button, and when you push it, it asks you how much do you want me to flush with, and you can enter a one-time flush amount of 20 mils. That's a really awesome thing to take advantage of as well. Just another tool in our bag of tricks. So hypoglycemia protocol, or the review. So hypoglycemia, being aware of when our patient's tube feeds are on hold will also decrease the how often we have to treat hypoglycemia. And CNAs, just refreshing on your critical thinking and clinical skills will also decrease this hypoglycemia, which can become fatal. If you think in terms of sugar, carbohydrate and sugar, the brain is fed by sugar. The brain is fed by glucose. Glucose is energy. So when you're thinking of terms of symptoms, what kinds of things are you going to see when the brain is starving? What kinds of energy levels are you going to see when the patient is starving for this glucose? You're going to see this shakiness, anxiety, nervousness. Some patients have even kind of described it as a sense of impending doom. I know something's happening, something bad. Confusion. They're very sweaty. And I mean, like 1 second you're talking to them and they're fine, and then boom, they are dripping sweat. Palpitations, fast heart rate, clammy. They're very sweaty, but also like a clammy feeling. When you think in terms of the brain being starved, you're going to see they're both hungry and they're nauseous at the same time, and they have a headache. A lot of times, because of the brain involvement and the brain being starved for energy, you have a headache with this. This is actually a very common symptom. So just reviewing on that and letting you guys know, you are also very key in identifying when a patient is starting to become hypoglycemic. Maybe they're not even on the threshold yet of a hypoglycemic event, but you are more than welcome to. I think all of our CNAs on the floor now have the barcode to access the blood glucose machines. We have a standing protocol. Anytime that we think that a patient is dealing with low blood sugar, we can check their blood sugar. The doctors have created a protocol in order that will cover in the event, anytime you believe a patient is having low blood sugar, you can check it and that order covers it. For a blood sugar less than 70, we implement the hypoglycemia protocol, and we're going to talk more about that in depth in just a minute. But if a patient's blood sugar is definitely less than, but if a patient's blood sugar is anywhere around 70, tell the nurse immediately. The CNAs, if they can drink, take stuff by mouth, give them some juice. That's the least invasive action to take at that time. And I guarantee you, if the nurse comes in with a blood glucose machine, they will thank you profusely for giving them juice before they check them, and hopefully they'll be greater than 70, 71. Yeah, so less than 70, that's when the hypoglycemia protocol jumps into place. I included this mainly for the PDF so that you'll have the documentation. and just a really quick nitty-gritty review. But as for going over the rest of this, we're going to be doing that in the protocol from here on out. All right, CNAs, I told you I'd tell you when you're apart, you are more than welcome to leave the meeting at this time or continue. It's totally up to you. And I've got Dina, Talia, and Kim Conley on the roster as attending remotely. If I've missed anybody remotely, please let me know. All right, so CNA or nurses, continue with the hypoglycemia protocol specifically. You're going to see this order set pretty much everywhere around the nurse's station. What I'm going to be just refreshing with you is that, yes, we are going to be giving them, doing these treatments specific to their assessment. Is the patient awake, alert, or not? Or has their baseline, their level of consciousness declined? What is their blood sugar level? And finally, what access does the patient have? And we're going to be treating them with the least invasive action per their access. If a patient has a PR per tube access, we're going to be giving them juice. If a patient does not have a PR per tube, if they only have IV access, then we'll be giving them half an amp to an amp of D50 plus starting at D5W. If the patient has no access, that's 1 milligram of glucagon, IM. We cannot repeat this IM glucagon, so we're definitely getting an IV or IO access in case their blood sugar drops again, and starting a D5W drip. And then the same and so forth for not awake, not alert. For these patients, we call a rapid response just to make sure that the hypoglycemia is indeed causing their symptoms. When you're in ProTouch, this is what you're going to see. So from the main page, go to telephone orders like you're putting in an order. Enter the time of the event or the time of, well, whatever. Select the attending doctor. And then you're going to go down here to facility order sets. This is a hidden gem that a lot of nurses forget about, this resource right here. Facility order sets, St. Anthony's, and you've got your CareNote education orders, but specifically for right now, your hypoglycemia treatment. This is your hypoglycemia treatment order set, and it follows the exact same pathway. Is your patient awake or alert, or has their baseline level of consciousness declined? What's their blood sugar? What's their finger stick blood glucose? What's their glucose level? Is it 50 to 69 or less than 50? What's their access? Do they have PR per tube access? Do they only have IV access, or do they have no access? You will click what's appropriate for your patient, and it's going to give you a list, all the different things to follow in this protocol. You will always have at the end this click here, all orders button. These are the orders to actually document against. So when you click them, it'll follow you through the prompts of ordering it. These are the 2 actionable items that you need to document in ProTouch. Rechecking 15 minutes after treatment, and the treatment being 4 ounces of juice. All right, now you're going to do this for every single recheck. So a hypoglycemic event, let's go over a couple of definitions that I've noticed nurses are a little fuzzy on. The hypoglycemic event is, yes, a blood sugar less than 70. However, that one event duration includes 3 retreatments. So that means 1 event report, 1 change of condition, and 1 questionnaire for that entire event duration. If you recheck their blood sugar 3 times and their blood sugar is still less than 70, that's 1 event report, 1 change of condition, and 1 questionnaire. You don't have to do an individual one every single time. That's a lot of, I know, that's a lot. And then the treatment, the documentation, the questionnaire, and then calling the risk management hotline number with the details of the event. So we'll go over that in just a second. And the rest of this is just further review of the process. The facility order set in ProTouch, the hypoglycemic questionnaire. This is what it looks like. And then again, just from start to finish, what it looks like. So in ProTouch, so you've done the treatment and the reassessments. We're going to go to reassessment. You're going to put the time that the event occurred. So if it occurred at 11 o'clock, change a condition, and we're going to add to this list. Here's a hypoglycemia. So you're going to create a hypoglycemia change of condition. This change of condition is then for the entire event. Whatever you document at this time, if you need to add more documentation, you can come back and document under the same change of condition. You don't have to create a new one. So each of these needs to be documented against. You're going to do signs and symptoms, observations, sweaty, confused, finger stick, blood glucose, we'll say 52. And you don't have to be, just remember that this is a legal document, but you don't have to be more, you can be as detailed or less as you want, as long as it's, when state looks, when they come in or they start looking at the hypoglycemia change of conditions, they are looking at these individual line items. A lot of nurses are adding everything under the comment. That's fine. However, you will need to copy and paste all that documentation into each of these, which actually ended up being quicker to just do these. Vital signs. So what you document here will flow over to the flow sheet. You have to document the vital sign, document the MD notified. Let's say Radoy. And you're more than welcome to document on this after the event is completed. So family notified, you cannot just put Susan wife. You have to put the full legal name. You want whatever you put in here, you want it to not embarrass you if it comes up in court. Let's say wife/POA. Treatment initiated, 4 ounces of juice, followed Hypoglycemic Protocol. And just to show you that you can copy and paste from these sections, finger stick blood glucose, or sorry, recheck. Finger stick blood glucose, let's say it was 58. Now you can document everything once you're done with the whole event. You can document each of the initial treatments, response to treatment. You can document each of them. Maybe the second treatment. Yeah, let's say that was 48. It probably won't go down, but 82. Finger stick blood glucose. Oh, wow. Yeah. 8 ounces juice. Well, you get the idea. Something like that. And each time that you're checking their blood glucose, it's going to cross over. And this is what it would look like once you're all done. You know, process that data to save it, and you're done with the change of condition. Come down to interrupt and event report. So again, the time that the event occurred, whatever your ASCOM number is, inpatient, patient room. Now, a hypoglycemic event will always be a level 2. Here are the definitions. A hypoglycemic event requires minor treatment. It requires treatment to correct. A fall without injury will always be a level 1. A fall with injury will always be a level 3. But just, and you're more than welcome to review the definitions. Just also know any hypoglycemic event will always be a level 2. It'll always be put under as an adverse drug reaction, and you can just put in insulin. The biggest thing about this event report is the timestamp. You're creating one in real time. When pharmacy and quality get the questionnaire and they review the change of condition and they review the voicemail on the risk management hotline, they can come in here and they can edit anything that needs editing. Maybe it wasn't a medication, maybe it was a medication variance or something to that effect. What they cannot do is they cannot create the timestamp of this event report. So this is asking what was the physical effect before, or what was the physical effect at the time of the event? What actually happened or was sustained? So usually for hypoglycemia, there's none apparent. It wasn't sustained. We treated it. They're fine. This is asking the next page, what was all of this prior to the event? Patient information, were they alert and oriented, or were they confused, agitated before the event? What was their functional level? Were they independent? Were they totally dependent? Possible event factors. The only time that I've ever clicked on anything was change of shift. Maybe their hypoglycemia would have been caught quicker if it had occurred outside of change of shift. Most of the time you'll click like NA. Was the coroner? No. Organ procurement? No. Supervisor notification, and you'll put the supervisor's name. The time of notification. You'll probably want to notify the supervisor when you realize you're going to need a little bit of intervention. That way she's aware of it occurring and she's a good resource to have in your back pocket. Was the physician notified? Yep. Time, so it happened at 11, 3 rechecks, 15 minutes apart, plus treatments, so probably 13:37 maybe. Continue monitoring the patient, you know what I mean? Family legal representation, so again, full legal name. And they're probably going to be called right after the doctor. And this is what the event report, and that's it. You're done. Process, done. Slam bam, thank you, ma'am. Done with change of condition and event reporting documentation. You'll still do the questionnaire, and that's just checking off the boxes. All right, let's see if I can. All right, that's just like answering these, checking off the boxes. It kind of helps. It helps pharmacy, dietetics, and risk management know what might have caused this to happen. How do we prevent it from causing in the future, and thankfully they didn't die, so let's do everything that we can to prevent this from ever happening again. Maybe their TPN was changed, or maybe their tube feeding was changed, and this will clue everybody into maybe something is not jiving with the patient very well. That's where the hypoglycemia questionnaire comes into play. So binders in the supervisor office. This is to let you know what resources you have available. So the discharge, this goes out for my two supervisors. Well, all of them who are going to review this this WebEx also. So you guys, the discharge location is it's not being documented when the patient is discharged. This is done in Meditech. Right now, Travis and HIM is completing it for nursing. However, this is going to be changing. He's putting together a step-by-step, which literally it's 3 clicks in Meditech, and then you put in the specific description of where they were discharged to, so that medical records know exactly where to send all their files, all their medical records. So we'll be going over this in the near future, adding this to the discharge management. Outside of that, nurses, admission, discharge, CareNotes, and blood transfusion review. Admissions. This is what you're going to see on every single Kindred desktop. You've got access to ProTouch training and ProTouch videos. The ProTouch training, let's see. So you have Connect, and more importantly, that's not what I wanted. I wanted the desktop. I want the desktop. Show me the desktop. All right. On all my icons. All right. So here you've got ProTouch videos, ProTouch Pathfinder, which is our charting Pathfinder, and ProTouch training. When you click on ProTouch training, this brings you to the same area where you could view the video. We're going to be watching a part of this discharge management video, not so much to watch the whole video, but more to give you an idea of where your resources at the time that you need it. And they're openly available right on the desktop, every single Kindred desktop for you. So work instructions, when you click on this area, it's going to ask you to find your specific role. So registered nurse, and what I do here, if I'm looking for discharge, now it's Connect, so it's stupid. It's not smart, it's not Boolean. But when I hit Control F together, it opens up this find box, and I can start typing in discharge, and it will tell me if it sees any matches. So here's one, discharge management. And that's great, but I'm really looking for, let's see, what did I do? What did I do? Nursing actions, and then I just click on this discharge, this find box again, and it's saying 4 matches. So there's a MedRec discharge, there's my discharge management RN. So there's our pre-day of and post-discharge activities. This is exactly what's in the binder in the supervisor's office. When you look up right on the top shelf, there's discharge help, admission guide, and our blood transfusion and CareNotes guide and cheat sheets. So this is our discharge management, and it walks you through all the steps. The binder will even walk you through additionally the differences between discharging to a hospital, to a SNF, or to home. And the differences are pretty much just the prescription pads, how many are needed, and then walks you through all the ProTouch documentation needed, document receiving facility report, the discharge note to the report to print off for the patient to sign. And then this is discharging or discontinuing all the physician orders upon discharge, resolving any of the care plans or updating them that you need. So this half is for the supervisors alone. And this is where the supervisors will actually discharge the patient from ProTouch, but the nurses complete this side of it. And then this is where document the charting summary. All right. I'm going to go back to, my notes have a little bit more highlighted than Connect's generic, and these highlights are also in the binder. So this is just a really nice review. And then this goes through the MedRec, how to do the medication reconciliation part of admission or discharge. There we go. All right, we'll watch a small part of the discharge. Stop. I didn't tell you to play. I don't believe that you guys can hear the audio, so I'm going to share the actual, I'm going to share it in a multimedia window. And so you'll see a link pop up on the side of your screen. And you'll need to click on that to continue to view the discharge management video. So we're only going to watch a few minutes of it. You can click around in the video if you want and see how they organize, how they, the resource of the videos. And this is like the perfect display of what that desktop application Kindred videos provides. Yeah. All right. All right, I'm gonna have you guys pause your videos. I would even right click on them. And what you can do is you can copy the video URL. And if you want to watch it in detail after the training session, that's totally fine. I'm not going to make you guys watch all of it right now. I really just wanted to use it to display um, a really good example of what resources are provided on the homepage or on the desktop, the all Kindred desktops in that Kindred training, Kindred training shortcut. All right, I'm going to jump back to, all right. So we reviewed, yep, we reviewed those. All right, CareNote, education and education order and blood transfusion, and CareNote, education orders to document that education was provided. Here is the step-by-step. This is what is included in the binders. I'm going to show you our so when you're looking at why do I have to? Oh, okay, because I'm still showing my desktop, not that application. When you're on Connect, this is the Connect home screen. When you go to hospital division, it's alphabetical, and if you click down to MicroMedex, you're going to see the CareNotes option. When you click on the CareNotes, it brings you right to here. You also have this option in ProTouch. Why is it doing that again? I've already shared it, so why? Okay, we've also got this option in ProTouch. From the retrieve site, click retrieve and go to web links. Under web links, you've got access to MicroMedex. So if you're in the patient's room, you can click on MicroMedex. Click on CareNotes, and you'll see one of the reasons why I don't use MicroMedex through ProTouch if I don't have to. You will be able to use it, but you will be clicking yes, continue running these scripts throughout the whole time that you're accessing MicroMedex and CareNote through ProTouch. But it is possible, and you can search for, like if you're doing medications, you can search for medications, add it to your print work list, hit search again, and go back to looking up another medication. So that's why I really like going through Internet Explorer or Chrome or whatever you pull it up on. So let's just look up blood transfusion. So you click on blood transfusion and reactions, select titles, general information in the language that you wish the information to be displayed, add to print list, and I clicked add to print list to show you how easy it is. Go back to search, and you can search for another medication or procedure, whatever you are you're needing to get a consent on or educate the patient on. You can look up as many options as you want. Let's look up maybe hemodialysis. And you can click on hemodialysis, general information, and add to print list. And then when you're ready, when you're done, click the print list. It'll show you everything. And I click customize. Click customize and add, again, legal name, patient's name. So maybe John Jones And whoever is giving consent, if somebody is giving consent outside of the patient, their full legal name. Wow, Susan Jones has had a busy day. Susan Jones is wife/POA. Oops, hang on. And then what I do, oh, come on, go back. Nope. You're not going to play nice? Okay. Which one are we on? We're on this one. Add Kindred Healthcare headers and footers, and then preview. So this is the first page, the summary page that's going to print. I usually throw this one away. I want their signature on the actual page, displaying the instructions I gave them. So if the patient is able to sign, great, have them sign there and sign as witness next to the signature. Same as you're going to do on the consent. If the patient is able to sign his own consent form, you're going to sign as witness. If there is a person giving consent for the patient, there needs to be 2 signatures, especially with telephone consent. So you'll just write the same thing that you would write on the consent. Telephone order given from Susan Jones, wife POA, at date and time. And then your signature and another nurse's signature. And then this goes over all of the information to discuss with the patient for informed consent. All right. All right. So that goes over pretty much everything that we just went over. And that's all included in the binder. This is how to create the education order in ProTouch to document that the education was provided. Now I'm also going to switch back over to ProTouch really quick and show you another nifty little thing in ProTouch under our favorite facility order set. So when you're here, when you're on the main page, go to telephone orders, the attending, facility order sets, and click on CareNote education orders. I have gone in and now keep on adding generic procedure. You've got the blood transfusion reaction, education order already created in your order set. Dialysis and hemodialysis already created. All you have to do is click on it, add new order. You want it to be done by a licensed nurse. It's saying how often. Well, we just need to do it this one time. And proceed. Yes, right back to physician. And process that out, and that will create the order rather than going through all those steps, which are in the binder in the event that you have to create a new order, maybe for a bronchoscopy or a chest tube insertion or something else that requires consent, that requires informed consent. That information is in there. So this is what your blood transfusion information should look like. This is what your hemodialysis will look like. And these are also saved in the nurse supervisor for you supervisors. This is also saved in the nurse supervisor folder on the common drive for you to print off whenever you need one. Okay, going on with blood transfusions. To look up a policy, again, on the home page of Connect, the easiest way to do it is to click on this Human Resources and Payroll and give it just a second, and it will open up this page, and then you click on Policy Manager. That is the easiest way to access Policy Manager. And again, Kindred and Connect are not smart searches. You will need to look up one keyword at a time for it to look up what you want it to look up. So going back to Let's go back to the home page. And we're going to click on Human Resources. Give it just a second. Policy Manager. Kindred Hospital. And like I said, so I want to look up transfusion. Here is our transfusion therapy policy. So it'll walk you through, it'll walk you through the entire policy. So I don't print this off because I want you guys to access the most current policy in Policy Manager. But it'll walk you through everything, including what to do in the event of a reaction. It's got at the very end, it's got compatibilities listed. All right. So you know how to access this policy. And we're going to be talking about the documentation in just a second. Let's go back. All right, so this is the audit form that the supervisors and I created together. And this is the cheat sheet. All of this is in the binder. This is the cheat sheet. It leaves nothing for guesstimation. It'll tell you exactly how to, what to do with the order, what to do with the cooler, all the way down through starting the blood transfusion. This is the form. You have to complete every single line. It's got 2 columns for 2 units of blood. What I do is I put a Mercy sticker right here because the MRN number on the sheet needs to match the MRN number on the blood and the blood bank number. Then the blood product type, blood product information, compatible, not compatible, visual inspection, blood component release 2. You are more than welcome to sign this. A lot of times we send the unit secretary or a CNA to go grab the blood. They will always put a release form in the cooler that will have the date and time that the blood was released. You can put that date and time and sign, and that takes care of that line item. 2 patient identifiers. You want the nurse, the signature of the RN spiking the blood. It has to be an RN. There has to be 1 RN verifying the type and cross. There has to be 1 RN verifying the blood component, and the RN has to spike the blood. The RN also has to complete the first 15-minute assessment, initial assessment for reactions in that first 15 minutes. After that, it can go back to the LPN if it was the LPN's patient who needed the blood transfusion or delegation to the LPN. So baseline vital signs, the time that the blood was started at, 15 minutes from start time, 30 minutes from start time, 1 hour from start time, every hour until completion, and then the vital sign at completion, the signature of the nurse who is discontinuing the blood, and 1 hour post-completion vital sign, and then the patient's response. So this is in triplicate. The original goes to the chart, the yellow is going to go to DQM, and the pink is going to go to the supervisors to complete the audit, the blood transfusion audit. This is the form that we use down at Lindell. I've been trying to get them to, but they use Red Cross, so that's why it's slightly different. All right, high 5 TPN. This is actually a new, this is not review, this is a new process. So we are going to be changing every single TPM bag change. Pharmacy is now going to be providing a baggie with all the equipment required to change out everything with that TPM bag change. And it's called a high 5. So, and these, okay, so we've got new grad nurses starting. This is not meant to talk down to any of you. It really is, I really did add these for their benefit. So these are Keros caps at the end of our lumens. And these are also Keros caps, but at the end, for the end of our IV lines. These are IV connectors. So just so that everybody's on the same page when we're talking about one or the other. This is the bag that pharmacy will be including instead of just the filter now, the TPN or the lipid filter, they're going to be providing everything for the entire what needs to be changed at bag, TPN bag change. So high five, perform proper hand hygiene, assemble the new IV tubing, apply this Curos cap to the end of all of the Y port connectors on that IV tubing, prime the IV tubing with TPN, assess the IV site and change the dressing if it's not intact, remove the current IV needleless connector, this IV needleless connector from the lumen, from the dedicated TPN lumen. Scrub the hub for at least 10 seconds with one of the alcohol pads. Apply a new IV connector. Flush with at least 10 mils of saline. Actually, I'm going to change that. I want 20 mils because TPN is grody. It is sticky. It is bleh. So flush with at least 20 mils of normal saline. That's why you're going to have 2 normal saline syringes. Scrub the hub for greater than 10 seconds. Connect that new TPN IV tubing once it's been primed. And then set up the IV pump according to the TPN's ordered rate and documented it as completed in ProTouch. Should the TPN be disconnected for any reason, we will always apply a new IV tubing Curos cap to the end of the TPN IV line and to the end of the lumen. Oh wait, where does the sticker? Okay, I need to add that too. There's going to be a orange sticker. You're going to take that TPN lumen orange sticker and place it, take off the old one, place it on the dedicated lumen so that we can easily identify which PIC lumen is the dedicated TPN line. You still have the IV label that comes in with the IV kit. So you're still attaching that to the IV line because the IV tubing, the IV is still going to be labeled and replaced every 24 hours. And then this TPN lumen sticker is, and the TPN and the needleless connectors are changed with every single bag change. So the IV line should be changed at least every 24 hours, if not more frequently, just by how often the TPM bags are reordered. All right. Mercy Link. This is just to review and let you guys know the current most up-to-date information on it. So Mercy Link is going to be replacing Mercy Connect Epic. This is what it's going to look like. So be checking your Kindred email for Mercy Link access. They will send one email with your username. They will send another email with your password. The link to use is mercylink.mercy.net. This is replacing the current mercyconnect.mercy.net Epic access. At this time, go live is September 1st, but it changes each call. Right now, Mercy Link is view only. We are setting up the order process. We're going to be using rec forms, and how exactly we're going to be submitting those, that's still in discussions. But be checking your Kindred email. I have been aware that Mercy has been inactivating some of our Epic accounts, so I'm replacing those with Mercy Link access and asking Jen to fix that with Mercy to stop doing that so we can still enter orders while we're figuring out this process. But please let me know if that happens to you. This is, let me show you the desktop again. Oh, come on. Why didn't you? Desktop. No, not yet. Desktop. Where's the desktop? Let's see the desktop. There's the desktop. Maybe. No. There we go. Okay. You're going to see one of two. You'll either see this Kindred Mail shortcut or the Microsoft Office shortcut. You might still see the Microsoft Office shortcut. Sometimes it won't work because Kindred is phasing them out. But you will always be able to access this Kindred Mail email icon shortcut. This is when you log into a computer, this is the icon. That is the stop. The current or the your email. Yeah. And I can also talk to you guys about how to view it on your phone, your emails on your phone. That's all. Thank you guys very much for your time. All right, we ran a little bit over 45 minutes, but I still think, I can shave off a few more minutes of that. Thank you. If you have any questions, just
Thank
hey.
you.
All right. Have a great evening. Thank you so much for your time.
You too. Bye-bye.
Bye-bye.